Okay, great. So this is the traumatic hand examination lecture. So traumatic hand exam, there's some important components. You don't want to miss any of these. First thing is inspection. Don't get tunnel vision. If you get consulted for something or you get told that something's coming in, make sure you're really looking for other injuries. Palpation. It's important to palpate things, but sometimes things might show up on an X-ray that are essentially just things that are going to confuse you because maybe they're not tender in a place where it's showing maybe a potential fracture, an agent determinate fracture. So you want to palpate and see if there's tenderness in all those locations. Motor examination. This is important. You want to rule out nerve or tendon injuries in the traumatic hand. Vascular examination. This is where you can really get into trouble. You don't want to send a dysvascularized hand or dysvascularized finger home from the emergency department or from your office. And then sensory examination. That's certainly important as well. So where to begin? Well, inspection. You want to look at the hand and look and make sure that you can see good muscle tone. Muscle atrophy is a sign of a lot of chronic issues, but not having a lot of muscle bulk in the thenar evidence can be actually a sign of a nerve injury. They got the recurrent branch of the median, and we'll talk about that in a little bit. But just inspecting for injuries and again palpating. You want to look for the normal cascade of digits, and we'll talk about that in the next slide. And any gross deformities, fractures, or bruising. If there's bruising, that's a telltale sign that there might be something going on underneath that bruise. So just kind of get you acquainted with the language that you want to use when you're doing a hand exam or a consult, writing about it. This is the small finger, affectionately known as the pinky by a lot of lay people and actually a lot of providers, but definitely call it the small finger. You have the ring finger right here, the long or middle finger, and index finger, and then the thumb. When people say it's the first or second, third digit, whatever, confuses hand surgeons because we call this a thumb and don't consider it really a finger. So when you say first, second, or third, we think, well, maybe this is the first, maybe this is the second, or this is the first. It's just kind of confusing. This is a standard way of kind of talking about it. Then ulnar side of the hand or wrist is towards the ulna, which is this big long bone right here, and radial side is this way. So if I'm trying to, for example, talk about this location, I would say, well, it's on the long finger and on the radial side of the long finger, so towards that purple arrow. These are the different joints of the fingers. This is the MCP joint, metacarpal phalangeal joint. This is the proximal interphalangeal joint, and this is the distal interphalangeal joint. So MCP or MP, PIP, and DIP joints. This is actually one of the most important joints in the finger. You get about 110 degrees of flexion there, and only about 50 to 65 degrees of flexion here. So you really, we're as in hand surgery concerned about this joint a lot of times. So normal cascade of digits is an important thing to look at, as well as pacitinodesis. So here's a little video playing of both of those. What you want to have patients do for you to rule out fractures, even before you look at the X-ray, is kind of how to make a fist. And that's a normal cascade of digits. You see that none of the fingers are overlapping when that person's making their fist right there. If the fingers start to overlap, I'll show you a picture of that in the next slide. You're concerned about angulation, maybe underlying metacarpal or phalangeal fractures. So all those fingers should kind of start to, as this person makes a fist, sort of work towards a single point here, which is actually the distal pole of the scaphoid, which is one of the wrist bones. They should all kind of start to point to that, and that's normal. And you can always compare it to the opposite hand. That's always a good way to look for things. This is passive. This is tenodesis. Basically, this video is not working unfortunately, but basically what you want to have somebody do is if you're concerned about a tendon, I'll stand in front of here so we get on video. When you're concerned about a tendon injury and say somebody's intubated, sedated in the trauma ICU, and you want to know if they have a tendon laceration or something that you have to explore and look into, what you can do is you can follow the normal cascade again of the hand. As you extend, your finger should flex. And as you flex the wrist, your finger should extend. And sometimes you'll see that if you have a dorsal hand laceration and you flex the hand, the fingers actually won't extend, they'll just kind of stay curled down. Okay? I'm doing that on purpose. But when I relax my wrist and relax my fingers and I just move it, you see how my fingers extend? So that's kind of the trick there, and that's what I'm trying to get across with that video. Alright, so here's an example of scissoring. That would be, maybe a fracture of the metacarpal on this finger. You see how they're overlapping, they're not all pointing at that one single point. So that's scissoring. That's a telltale sign that maybe there's a fracture there. Maybe you need an X-ray. So palpation. Like I said earlier, when there's potentially a fracture versus not a fracture on an X-ray, you want to palpate it. If they're not tender there, then follow up with electively in an office. That shouldn't be something that you're concerned about in the emergency department unless there's another reason. Again, with palpation or with inspection, you want to make sure that the story fits with whatever you're seeing or whatever you're palpating. Somebody got into a fight a few days ago and they had a laceration, now they're super tender. You want to be worried about things like fight bites, like people punching somebody's mouth and having some bacteria in their hand or something along those lines. So palpation and inspection again are very important. And you can see in this person, where I like about this picture, you can really see all those extensor tendons. And this is really one of the areas where a laceration, even pretty superficial, can get one of those extensor tendons because extensors are much more superficial than the flexor tendons. So this is actually one of the most common sites. It's called zone 6 for those interested of extensor tendon lacerations. So here's how you test motor. Get into sort of the nitty-gritty of the physical exam here. Here's some slides. We're going to go into each one of these. But we'll talk about the most distally inserting flexors right now. So the thumb has one joint between the proximal phalanx and the distal phalanx, the IP joint. And the flexor tendon that crosses that joint is the flexor pollicis longus, the FPL. So that's the only flexor that crosses that joint. And the way you test it, obviously, is flexion of that joint. You just want to isolate it and make sure they can bend their IP joint. Now for the fingers, the tendon that inserts the most distally is the FDP, the flexor digitorum profundus. So it goes through the carpal tunnel here, along with the FPL. Okay, very deep in the carpal tunnel, and inserts on that distal phalanx. Remember, there's three bones: proximal phalanx, middle phalanx, distal phalanx, and it bends this joint right here, the DIP joint that we talked about earlier. So again, to test those tendons, to test the FDP, you want to have them bend the distal interphalangeal joint. Really isolate that joint, have them bend it, and show that they have that one tendon that can do that, and it's intact. Again, here's the FPL, just an example of isolating the IP joint on the thumb. All right, and for the flexor digitorum superficialis, now the thumb doesn't have one of these, but the FDS is more superficial in the carpal tunnel in the wrist. It comes into the hand and inserts on the middle phalanx. Again, sort of mostly at the base, but maybe a little more distally in the middle phalanx as well. But these are where the insertions are. Of this tendon. So, obviously it's not going to flex the DIP joint. So if you want to test this one, you want to have it bend the PIP joint. And I'll show you how to isolate it though, because obviously that tendon that's inserting here also bends the PIP joint a little bit. So how do we test it? How do we test the FDS? Well, we take the rest of the fingers out of it. You want to keep those in a neutral position, okay? And you want to see if they can, as you're putting the rest of the fingers, as you can see in this picture, in a neutral position, you want to see if they can bend that PIP joint, okay? If they can bend that PIP joint with all the other fingers extended, then you know that you're really taking all the other fingers out of it, you're taking the FDP out of it, and you're isolating the FDS, and the FDS bends that PIP joint. So this person has intact FDS to the index finger. That's kind of how you describe that. Now, what flexes this MP joint? It's mostly the intrinsics of the hand. It's mostly those lumbricals that you learned about in medical school on the radial side of the flexor digitorum profundus tendon. So the way I like to think about it is that FDP flexes the DIP, FDS flexes the DIP, and the intrinsics flex the MP joint. So if you're worried about something in the hand lacerating, one of the intrinsics, or maybe they're, a nerve injury that's causing them to not be able to, use the intrinsics, or God forbid, compartment syndrome, have them do this and see if they can, and the MCP. Thumb abduction. One of the main muscles here is the abductor pollicis brevis. That's the superficial meaty muscle on the thenar eminence right there for the thumb, and that's innervated by the recurrent branch of the median. We'll talk about where that is. But what you can do for that is just kind of have them abduct their thumb, kind of have their hand sitting, maybe on the table and have them push their thumb up, kind of like this person. You can see there's really good muscle tone here on the thumb. I'm not just saying that because it's my thumb, but yeah, good muscle tone. All right, so testing the hypothenor muscles. There's the abductor digiti minimi. Okay. Ulnar nerve, we'll talk about that in a little bit, but you can just have them kind of abduct that finger. And you can have them abduct and adduct the rest of the fingers as well, just to test for intrinsic issues and lacerations that are oftentimes more subtle. Okay, so again, here's that, those really good extensors in this person. The way you want to test the extrinsic extensors, because some of the intrinsics also extend the fingers, they extend it to neutral, but the way to test the long tendons that are extensors is you have the person put their hands flat on a table or flat on their thigh and have them hyperextend the finger. In this instance, I'd be able to say, that maybe if there was a laceration back here, I'd be able to say, well, they're still able to extend their finger from neutral. So you could say with reasonable assurance that if you're really not concerned about an extensor tendon injury, that they probably didn't get it. Now there's connections in here on the dorsum of the hand that kind of confuse things. You need to have people explore lacerations or explore them yourself, make sure there's not a partial tendon injury. But this shows that at least it's working. It's, that's how you test for a tendon injury of the extensor digitorum communis, is what we call it, EDC. Is to really have them hyperextend the finger from neutral. All right, so sometimes if they have an extensor tendon injury very distally, you can get something called a mallet deformity. This is a pretty common thing. This kind of goes along with kind of the inspection, maybe palpation part of the exam, but also the motor, because part of the extensor tendon, if you look at the mechanism, there's part of it that inserts here called the central slip, and here's the terminal slip. There's also another part, a couple bands here that work their way out across the DIP joint and insert at the base of the finger here. And sometimes if you get hyper flexion, if you're trying to extend your DIP joint, you get hyperflexion or a lot of flexion from something, you get, again, hit by a mallet or you get your finger crushed in the door, you can get this problem where the extensor that's supposed to insert at the base of the distal phalanx is actually evolves from that. Maybe there's a bony component, maybe there's an avulsion fracture here with the tendon, and again, you can't straighten your finger all the way out, it's just kind of fixed in a bent position like that. So look for that. Treatment is DIP extension, okay, and just send it for follow-up with a hand surgeon. Don't immobilize the DIP joint. Again, that's a pretty important joint in the finger. You want to make sure, because people can get pretty stiff, that you're not immobilizing that unless you absolutely have to. Now, nail bed lacerations that are associated with the mallet finger, especially in children, can be a bad thing. Again, this goes along with on a traumatic exam with kind of the inspection and kind of looking at the whole clinical picture. Now, if a child comes in with a mallet deformity and they have a laceration in the dorsum of their finger, you worry about nail bed injury for these kids, and you worry about having, if there's a fluid collection underneath the nail, a subungual hematoma, it requires further explanation. You want to look to see if it's an open fracture, okay? Because when there are open fractures, sometimes this soft tissue can get actually caught between, within the growth plate, between the distal, bony fragment and the growth plate and the proximal epiphysis here. And you can get soft tissue in a position that can prevent that finger from growing well, and they can have a deformity, for the rest of their life, or osteomyelitis, and potentially require an amputation. So it's kind of a bad problem if it's not addressed initially and not diagnosed initially. So something I wanted to drive home. Now, vascular exam, again, this is a pretty important part of our talk here. Now, there's a lot of variation in this, but there's sort of some key points. Most of the blood supply to the hand actually comes from the ulnar side of the hand, okay, through the ulnar. Some people say 5/8 of the blood supply to the hand comes from the ulnar side. So that's really the most important artery that goes to the hand. The radial side obviously provides a collateral blood flow and an important blood flow, but some of the orthopedic literature will say that if you have an isolated radial artery injury and the hand is well perfused, we'll talk about how to test if it's well perfused in a second, that you actually can just ligate it and not worry about it. The plastics literature actually will tell you that you should repair it because there's problems with cold sensation, temperature issues, and pain sensation. So what do we do? Well, we repair it, and probably right, because it's our literature. So, but again, I'm kind of biased. So both of these are important that people diagnose and rule out because they are obviously again blood supply. Your hand, you can be radially dominant. You can have a hand that's only perfused well from the radial side. So you need to kind of rule that out in every wrist laceration or hand laceration. So what do these guys do? So they come across the wrist here, and they form two arches here. Start with the ulnar side here. It comes and it forms the deep palmar arch, gives off this branch, okay, and the distal superficial palmar arch, which is actually at the proximal palmar crease. Is where I start looking for it. So that's important. It gives off these digital arteries, okay, to each of the fingers. There's really three big common digital arteries, one for each of the joint, and one for each of the web spaces here. And there's also some collaterals that come here from the deep palmar arch. Okay, so everything's kind of interwoven at this point, and there's a lot of variation. But the main thing is that there's a deep one and there's a superficial one. And the superficial one is superficial all the tendons. I tell people that the hand bleeds and the fingers feel. We'll get to the fingers feeling in a bit, but the fingers have nerves that are more volar and more superficial, and the hand has arteries that are more superficial. Now, it makes a nice little arch here with the radial side, the deep palmar arch anastomosing with the dorsal branch of the radial artery, and the more superficial arch here anastomosing with the radial artery that crosses the wrist here, and they give off arteries to the thumb here.
Okay, so we want to do a Doppler exam of the hand here. So it starts on the radial side of the wrist.
So test hand perfusion.
She has a really great signal for the radial artery. Here, triphasic signal there. Let me go to the ulnar side of the wrist. Sometimes the other artery is a little bit harder to hear, but again on her, she has great signal there. All right, so we know that there's good inflow from the wrist. So we're going to find the palmar arch here. Now the superficial palmar arch is usually at the level of the proximal palmar crease. So we come there. Okay, so she's got great flow. Great flow into the proximal, or distal palmar, superficial palmar arch, proximal palmar crease. So at this point, I'm going to include both the radial and the ulnar arteries of the wrist. Okay, and I'm going to let go of now the radial. And now I can hear that there's really good inflow to the palmar arch from the radial side of the wrist. And now I'm going to include the radial side again. So again, no blood flow going into the hand. then I'm going to let go, and I still hear flow from the ulnar side of the wrist, now that the radial is just occluded. So that demonstrates that there's good flow from both the radial and the ulnar side into the arch. And I know our hand is well perfused.
All right, so that's an important thing.
Okay, great. So I'm going to bring out.
We're going to pause this for 1 second and just say, if you're worried about one of those massive arteries, the wrist being lacerated, you need to do a Doppler exam. It can't be enough to just say, well, there's good cap refill, because we've replanted some fingers that had good cap refill, like fingers that were cut off that still had kind of blanching, underneath the nail bed and everything. So it's really important that you get a good Doppler exam and document that, and really check the hand for good perfusion from both sides of the wrist. Now here's how you test the fingers for blood supply, good blood supply in a traumatic hand exam with the Doppler.
Dad's radial digital artery on our index finger here. You can hear it now. It's on the volar aspect of the digit, just probably at the level of the crease of the PIP and the DIP joints. We found it pretty easily here. She's got good blood flow. So what you can do, if let's say there's a laceration right here and you're concerned about an injury, well, you can just Doppler distal to the zone of injury. So if there's a cut here, if I got some signal at this point of her finger, this part, I would know that, well, that finger's pretty well perfused. There's unlikely to be a digital artery injury there. Again, you probably want to get somebody involved who can explore it and make sure there's not an injury there, but you're pretty confident at this point. And another thing you can do to make sure that the finger's getting good blood supply, if there's a laceration somewhere more proximally and you're concerned about a dysvascularized hand, is to keep the Doppler on the digital pulse right there, and then occlude the wrist, both the ulnar and the radial, and then let go of one side. Okay, so let go of the radial and there's good blood flow to this finger. Include both again. Let go of the radial side now. And I hear that she's getting excellent blood flow from the ulnar side. So I know that she's getting at least flow to the index finger from both the radial and the ulnar arteries.
I think the person in the video had him reversed there. Shame on him. But yeah, it was, anyway, he made a good point, which was that the finger was well vascularized from both sides. So nerves. Just want to kind of show you that this person's using some nerves right here in this picture. And there's an important nerve that helps move the thumb, move some of the muscles of the arm right here that goes right in between these two tendons. This is kind of a good landmark that physicians can use and consultants can use. It's the palmaris longus right here. It's kind of that big thing that goes up here and splays out into the palmar fascia, covers the transverse carpal ligament and the carpal tunnel there. And right here, this tendon right here is the flexor carpi radialis tendon. In between them is the median nerves. You have a laceration right here, especially in someone without a palmaris. The median nerve's right under there, and we want to be looking for that. So here's the ulnar artery that we were just talking about, kind of where it runs. And here's where the ulnar nerve runs. The other point about this slide is that the nerve is actually more ulnar than the artery. I'll get a consult sometimes for ulnar nerve injury, ulnar artery injury, and I'll say, well, can they give me a peace sign? We'll talk about that in a second. I'll say, can they give me a peace sign? Because they'll tell me if the nerve's still intact, and if they can give you a peace sign and the ulnar nerve's working, then it's probably not. Especially if it's an ulnar wrist laceration, it's probably not an ulnar artery laceration. So here's how you test some of the nerves of the forearm and some of the muscles and tendons that are innervated by those nerves. Posterior interosseous nerve off the radial extends the thumb. So I have the patient give me a thumbs up, just showing me that that's working. And again, I also test the EPL. Anterior interosseous nerve off of the median nerve comes off in the forearm and innervates the FDS and some of the other muscles in the forearm, and that's going to give you the OK sign. So I also have them thumbs up and OK. Then I have them give me a peace sign. That tests the ulnar nerve because one of the most distally innervated muscles by the ulnar nerve is the abductor for the first digit. So when they give you a peace sign or they push against you with the index finger when they're giving you a peace sign, it shows that pretty much the whole ulnar nerve, at least motor-wise, is intact. Fromet sign, this is you can also test the ulnar nerve by having them kind of put a piece of paper in their hand like this between the index and the thumb and try to pull it out. And if they end up doing something like this, then they're actually using the AIN. They're using the anterior interosseous nerve instead of the ulnar nerve. This is a sign of potentially having an ulnar nerve injury. All right, now back to that median nerve. Here's it going right in between palmaris longus and the flexor carpi radialis. Comes into the wrist here and gives off recurrent branch of the median nerve, which does the thenar muscles here. Comes off right about where the ring finger touches the thenar eminence here. So normal cascaded digits, if you just kind of bring your ring in your palm, that's kind of where it is. And it's sort of a good landmark there. Recurrent branch of the median, again, a good way to test it, is to see if there's muscle bulk in that thenar eminence and kind of have your thumb do some abduction and some opposition there. Now, nerve anatomy, like I said earlier, the hand bleeds and the fingers feel. It's a good way to remember what's more superficial. So in the fingers, the artery's deep and the nerve is superficial, and that's where it runs. So if somebody has a laceration, this part of the finger, that's where you'd be really worried about, nerves or arteries. And again, you only need one of these arteries to perfuse, the rest of the finger, most people. So it's not, it's an urgency, but maybe not an emergency if one of these is lacerated. Still needs probably repair, but general rules, any deficit, you should get a hand consult. People, even if it's just a digital nerve or the difference between your finger bending a little bit or not as much, it's still, a deficit and still can be something that potentially be fixed. Any volar hand laceration with a deficit or volar forearm laceration with a deficit needs to go to the operating room. So volar is the anterior of the hand, kind of, or forearm in anatomic position, and dorsal is obviously the back of it. We say volar dorsal. And thank you for listening to the lecture. Appreciate you guys.